Welcome to the deep dive. Today we are tackling something that is, well, it's completely universal, but at the same time, it's utterly unique to every single person: pain.
It really is the ultimate paradox of biology, isn't it? And when you try to understand it clinically, you have to start with this foundational truth. Pain is defined as both physical and emotional.
Right, but get this. And this is really the core of our whole deep dive today. The clinical standard is that pain is whatever the patient says it is, and it exists whenever the patient says it does.
Exactly. And that just changes everything. Our mission today is to really unpack what that subjectivity means. We're going to go from, the tiniest nerve fibers all the way up to the huge psychological and cultural filters that shape how you feel discomfort.
Okay, let's get into it. So, because medicine has to rely on what someone reports, they've built a whole framework to understand it. Your ability to feel pain isn't just about how big the stimulus is, right?
Not at all. It also depends on how well your nervous system transmits signals, and maybe most importantly, what your mental state is at that exact moment.
So how do you organize that?
Well, clinicians break it down into 4 dimensions.
Mm.
The first one is location.
Mm-hmm.
Seems simple, but it includes two pretty complex ideas: radiation and referred pain.
Radiation, I think I get. That's when pain starts in one place and sort of spreads out, like down your leg.
A pinched nerve is a perfect example, but referred pain is different. That's when you feel pain in a place that's actually, nowhere near the real injury.
Like the classic heart attack example where someone feels it in their jaw or their arm.
Precisely. The source is the heart, but the brain interprets the signal as coming from somewhere else. It's a critical diagnostic clue.
Okay, so after location, what's dimension two?
That's intensity. This is the one we all know. The 0 to 10 scale.
But it's not just a number, is it?
No. To be useful, it's categorized. So 1 to 4 is mild, 5 to 6 is moderate, and anything from 7 up to 10 is considered severe. We even use visual scales, like with faces, for kids who can't really grasp a numerical scale.
And the third?
Quality. This is all about the language, the words you use to describe the feeling.
Like, is it sharp? Or is it more of a dull ache?
Exactly. Is it burning? Is it deep and cramping? Those words are vital clues for a doctor.
Which brings us to the last one, duration. And this one is the big one. It's the main clinical dividing line.
It absolutely is. This is where we get the huge split between acute and chronic pain.
So acute pain is the body's alarm system,
Yeah.
basically.
It's got a sudden onset. You can usually find the tissue damage, and it's short-term, maybe up to 6 months. And because it's an alarm, you get that classic fight or flight response. Heart rate goes up, you start sweating.
But chronic pain is different. It's when the pain just keeps going, long past when the original injury should have healed. We're talking months, even years.
And what's really striking is that those autonomic responses, that fight or flight stuff, it starts to fade.
Yeah.
The body just adapts to this constant state of discomfort. The alarm bell gets tired.
And even within chronic pain, there are different types, right?
Yeah. We break it into 3 categories. You've got chronic recurrent, which comes and goes, like migraines. Then there's chronic intractable benign pain, which is constant, but not from something immediately life-threatening, like really bad low back pain.
And the third?
Chronic progressive. This is the one that's relentless. It often gets worse over time, and it's usually tied to an underlying condition that's also progressing, like cancer or MS.
That distinction really frames chronic pain as a disease in itself, not just a symptom that won't go away. So, okay, let's zoom in. Let's go microscopic. How does the body's wiring even create that first signal?
So we start in the peripheral nervous system. You have sensory neurons that detect stuff and motor neurons that make you, pull your hand away from a hot stove.
And the actual pain receptors have a specific name?
They do. They're called nociceptors.
Oh.
And here's a wild fact. They are everywhere in your skin and muscles, but you have 0 in your brain.
None in the brain itself.
None.
Yeah.
And they aren't stimulated by just pressure. They're activated by a chemical release from damaged cells, things like prostaglandins.
So it's a chemical signal that starts the whole electrical chain reaction.
That's the first step. But how the brain and spinal cord process that signal? Well, that's been a huge debate. And there are 3 big theories we need to understand.
Let's start with the oldest one.
That would be the specificity theory. It's the simplest idea. It basically says pain has its own dedicated highway to the brain. A unique set of wires just for pain signals, completely separate from touch or temperature.
A direct line for pain.
Okay. But that was challenged by the peripheral pattern theory. This one argued the complete opposite. It said all nerve endings are the same. Pain is just what happens when you stimulate any of them intensely enough to create a certain pattern.
So one theory is a special wire, the other is just a normal wire that's overloaded.
You've got it. But then, in 1965, Melzack and Wall came up with the gate control theory. And this changed everything. It brought psychology into the picture.
The gate control theory. This one I've heard of. How does it work?
Okay, so imagine a physical gate in your spinal cord. This gate decides if pain signals get to go up to the brain. The theory says that small nerve fibers, the ones that carry that slow, throbbing pain, they cause the gate to open.
And let the signal through.
Yes. But, and this is the genius part, the large diameter fibers, the ones carrying non-painful signals like touch, vibration, temperature, they cause the gate to close.
Oh. So that's why when you bang your elbow, the first thing you do is grab it and rub it.
Exactly. You're stimulating those large fibers, sending a rush of non-painful signals that literally closes the gate and blocks the pain signal from getting to your brain as strongly.
That makes so much sense. It's a perfect real-world example.
And the theory goes further. It says it's not just physical touch that controls the gates. Emotional factors like anxiety or being distracted can also open or close them. The subjective experience is wired right in.
So if gate control brought psychology into the spine, what's next?
The next big leap is the neuromatrix theory. And this one takes pain almost entirely into the brain. It's our most current advanced concept. It says pain isn't just a reaction to a stimulus, it's an output from the brain.
An output? What does that even mean?
It means the brain generates the experience of pain using a widespread neural network. It creates something called a neurosignature pattern.
A neurosignature.
It's unique to you. It's based on your genetics, your entire life's worth of experiences, your memories, your emotions.
So the truly mind-blowing takeaway here is that your brain can activate this network and create very real physical pain without any external injury at all.
That is the crucial insight. Your brain can generate the entire experience on its own. It just fundamentally changes how we have to think about chronic pain.
Okay, with that in mind, let's talk about the clinical types of pain based on what's actually causing it.
Right. We have two main origins. The first is nociceptive pain. This is what most of us think of as pain. A cut, a bruise, a sprain. It's an external stimulus on a perfectly functional nervous system.
And the other type?
Neuropathic pain. This is when the nervous system itself is the problem. It's been injured or is malfunctioning because of trauma or a disease like diabetes. It's the pain of damaged wiring.
And you can see this in really specific, complex conditions, like central pain.
Yes, that's caused by damage inside the central nervous system, a stroke, an injury to the spinal cord.
And the cruel irony there is that someone can be in constant burning pain, but at the same time, they might be less able to feel normal touch because the wiring is so damaged.
It's a profound paradox. And then you have phantom pain. For years, these just baffled doctors. How can you feel an arm that isn't there?
This has to connect back to the neuromatrix theory.
It does, directly.
Yeah.
It's neurological activity in the parts of the brain that were once connected to that limb. The brain's map, that neurosignature for the limb, is still there, and it's still being activated.
The brain is trying to complete a circuit that doesn't physically exist anymore. Wow.
Precisely. And a third complex type is breakthrough pain. This is that sudden, intense spike of pain that happens even when someone is on a regular pain management plan.
Right, and this is so important for people with chronic conditions. There are different kinds of breakthrough pain.
Three main types. Incident pain, which is caused by a specific action like walking. Idiopathic, which happens for no reason at all. And end-of-dose medication failure, where the medicine just wears off too soon.
Understanding that is so critical for managing quality of life. Okay, so we've done the biology. But if pain is whatever the patient says it is, we have to talk about the huge role of psychology, culture, and environment.
Oh, absolutely. Uncontrolled pain creates a vicious cycle. Physically, you get muscle atrophy, blood clots, but the psychosocial effects can be even worse. Depression, social withdrawal, fatigue.
It seems like the meaning someone attaches to their pain can act as a volume knob.
That's a great way to put it. If you see it as a sign of survival, you might have a higher tolerance. But if you see it as a punishment, it feeds hopelessness, which in turn amplifies the pain sensation.
And culture plays a massive role in this.
A huge role. It affects how you show pain and what treatments you'll even accept.
Can you give an example?
Sure, some cultures really value stoicism. A patient from that background might be in agony but will never say a word. So if a nurse only relies on that 0 to 10 scale, they're going to completely undertreat that person.
So the provider has to look for other clues?
They have to. They have to rely on body language,
Yeah.
vital signs like blood pressure, things that get past the cultural filter.
And our environment, our support systems, they can literally change the pain we feel.
Without a doubt.
Mm.
An unfamiliar setting makes pain worse, especially for kids. A strong support network can actually decrease pain sensations. And your previous experience matters too. One bad, painful procedure can fuel anxiety that makes every future treatment feel worse.
It all feeds back into that learned neurosignature.
Every single time.
So, given all the subjectivity, how do we actually assess and manage it clinically?
Well, the assessment is still a challenge. We don't have a blood test for pain. So we use those patient scales, but we back them up with objective things like vital signs or tests for stress hormones like cortisol.
And the management often involves a whole team, right, in special pain clinics.
Ideally, yes. And when it comes to medications, there's a huge spectrum, from NSAIDs all the way to opioids.
And with opioids, there's a critical distinction to make.
A very critical one. You have full agonists, which have a high affinity for the receptors and, importantly, no ceiling effect. More dose means more pain relief, but it also means more risk.
More risk of respiratory depression and abuse.
Yes. But then you have weak or partial agonists. These have a ceiling effect. After a certain dose, more of the drug doesn't give you more pain relief, but it will still increase the side effects. It's a kind of built-in safety brake.
And you can combine them with non-opioids to get a better effect at a lower dose.
That's often the best strategy, to minimize those side effects.
Speaking of which, nausea and vomiting are really common. Why is that?
It's complex. The drugs can activate something called the chemoreceptor trigger zone in your brain, which is basically your body's poison detector. But it can also just be irritation in your stomach or even your inner ear's balance system being thrown off.
Beyond drugs, there's a whole world of non-pharmacologic approaches.
The whole world. Physical therapy, acupuncture, meditation, and also complementary approaches like homeopathy or Ayurveda. The goal is to treat the whole person, to try and quiet down that neurological signature.
And surgery is always the absolute last resort.
The very last. Because
Yes.
when you start cutting nerve pathways, that's a permanent change. You can't undo it.
This has been such a deep journey. We started with a simple subjective definition, and we've ended up mapping it across nerve fibers, psychology, and even culture.
For me, the thing that stands out is the neuromatrix theory. If pain is really a neurosignature pattern that the brain learns and can produce all by itself, that has profound implications.
It shifts the entire focus, doesn't it? We stop just reacting to an injury, and we have to start thinking about how to prevent the brain from creating those patterns to begin with.
Exactly. So you should really consider how things like a healthy lifestyle, mental resilience, even just safety precautions. They're not just good advice, they are fundamental forms of pain prevention. And for those of you already dealing with chronic pain, remember the real barriers to relief aren't always physical. Sometimes it's a doctor's knowledge gap or your own fear of dependency or financial issues. Understanding that is key to advocating for yourself. So the question to think about is, now that you know pain is so deeply wired into your personal history, what change can you make?